Good evening, all the aspirants present here. Today's session is Station 4 Abdominal, and the faculty that we have here is Dr. Subhadip sir. He is a physician and in internal medicine and critical care. Sir, you may continue. Thank you. And to all the aspirant, it is going to be a very interactive session, so you can also unmute your mics or also drop a text in the chat box. Thank you.
A very big welcome to all my colleagues who have come this far to have cleared the part one and part two. In most of the cases, you have done that. And you are knocking the door of the membership of the Royal College. And trust me, this is the easiest part of the entire journey, if you can really believe, because there's a lot of misbelief around all this. PACES and the practical examination. But to be very honest, this happens to be the easiest part of the story. If you just follow simple rules, if you're just doing what you regularly do in your words, with a little change in the type of practice, in what you say, what you do, and how you do. So we'll do exactly that in next half an hour or a little more. I'm sure all of you by now have gone through numerous videos where you'll be able to find out how exactly you do an abdominal examination, where in the carousel the abdominal examination lies, and how exactly you are supposed to participate in the examination. So, as you know, in the carousel, it will be a 10 minutes station in the abdomen. And like all other clinical stations, you'll be given a case scenario, which is going to be very brief. You have to go in, examine the patient, finish it off methodically, but within time. By within time, what I mean is that your target should be to finish off the examination in 6 to 7 minutes flat. And trust me, with a good amount of practice, it is easily done in less than 6 minutes time. And once you have done that, you have earned yourself ample time, by virtue of which you'll be able to face, you'll be, first of all, you'll be able to compose yourself, you'll be able to have a little bit of breath, you'll be able to catch a breath before you face the examiner, give your diagnosis, or whatsoever the examiner asks you to. And in the remaining time, you'll be able to face questions, because in the PACES stations, you need not only do the clinical examination, you need to show them that you know your business. And thereafter, there's a lot of there's a lot of marking left over, where you come to know about where the examiner basically tests your skills to clinch a diagnosis, the positive signs in favor of diagnosis, draw a management plan. So there is marks dedicated, if not marks, there is grade dedicated to each of these sections, starting from communication with the patient to presenting the case, having a good differential diagnosis, having the positive cues favoring your first or primary diagnosis, and ending up with safety netting of your practice. Next, please. So, next. So, we'll talk about just the list which give you the common encounters in an abdominal station. So, this doesn't necessarily mean that these are the cases which you are supposed to get, but these are the commonest cases. And once you have gone through the list, if you can click and bring the whole slide into vision. So if you can go through the list, or even if you want, you can, there are more actually. Even if you can take a screenshot, if that is permitted, you will see that this list is pretty exhaustive. There's a lot of cases into this list. And apart from this, there are hardly any cases that are possibly given in the MRCP PACES. Does that mean that there are no other cases they want you to know? Certainly not, but they will never give you a very acute case. Like a case of abdominal sepsis, peritonitis, patient in shock, they cannot give you. Sorry. Acute pancreatitis in excruciating pain, passing on to ARDS with a flow of say 8 liters per minute in oxygen face mask, they're not going to give you. They can give you an abdominal aortic aneurysm, which has been already operated or which is sitting tight inside the abdomen for many, many years, and there's no chance that it is going to be operated. But they will never give you an acute dissection. They will never give you, as I said, they will never give you an acute flare of inflammatory bowel disease. And although you are supposed to get uh, I mean, real time cases, real life cases, but there will be situations where they'll be used as they'll use a semi simulated case. I'll tell you how. Maybe there's a patient with signs of chronic liver failure, which has now been decompensated. Patient has developed ascites, patient has developed jaundice, and the patient has also developed bleeding diathesis. And they give a short history to mislead you into a thought that this might be a drug overdose or drug induced liver injury. So, what do they want out of you in that case? They want you to think in line with the brief summary they have provided with. At the same time, they'll want that they will identify the stigmata of the chronic liver disease if it is present, so that you can say that I think the patient is having a uh, acute flare up of a chronic liver disease. Nothing like acute liver failure. An acute fulminant hepatic failure is never going to come up for a PACES. So this is basically the cases which commonly occur in the PACES in the abdominal station, but there are several other cases that you might encounter. Like we had a case of, even in the last PACES, we had a case of drug-induced esophagitis with halitosis. A very vague case, but there was a lot of clinical findings into that case, and there was a lot of scope for discussion. So, if the case is heavy, the questions would be less. If the case is very light, uh, looking simple, rest assured you're going to get a hell lot of questions and crossings. Next slide. Now, this is how you start the examination. You have to go in. Uh, for all those who are listening, how many of you enter the PACES station and greet your examiner? Anybody who is used to do it? Okay, I think that everybody is wise enough not to greet the examiner, because you are not supposed to greet the examiner formally and actually luxuriously spend 30 seconds of your precious 10 minutes. You can just give a simple nod and then proceed for the examination, unless the examiner asks you to do something else. Because I have seen people coming into us, telling that, good morning, sir, or good morning, sirs, unless we tell them, so here's your patient, why don't you proceed? By that time, they have lost one precious minute. So you need to introduce yourself to the patient. And you remember that if you get a patient who doesn't speak English, if you get a patient who speaks vernacular, if there's a interpreter involved, you still need to introduce yourself to the patient, facing the patient. Give every question to the patient. And while the interpreter is giving answers to your queries, it's absolutely decent to glance towards the interpreter, but primarily look at your patient, because that shows empathy, that shows that you are connected to the patient beyond the language barrier. So once you have uh, given your introduction, then you proceed for the consent. But before I talk about the consent, somebody please from the audience introduce yourself to a patient in the abdominal station. Say he's Mr. David. and you are going in and introducing yourself, how would you say that? Well, I think unfortunately have a very shy group. I have seen people going in, future members and fellows going in and saying that I'm Dr. So and so, and I am a student appearing for the MRCP examination today, or I am an examinee appearing for the MRCP PACES examination today. So that is not a fair way to do it. It's a full fledged encounter. It's better to say that I am the house officer or I'm the doctor here in the clinic today, and I wish to examine your tummy or examine your abdominal system if I have your permission. But before the consent and in between introducing yourself, is there anything else that hints your mind that is not there on the slide? Now, if everybody keeps mum, then
The
I'll.
hand
Sanitize
sanitization.
your hands.
That's there in the bottom of the slide. You can see wash hands.
Or check the name of the patient.
Absolutely. You reveal uh, the name of the patient so that you can address the patient in a dignified manner, taking his name or a surname, and at the same time, you're sure that you are dealing with the right patient. Because when you work in the NHS or you work in any standard facility in anywhere in the world, you have to divulge the identity of the patient. You have to reveal the identity of the patient. And that is so very important so that you see the lab reports are actually right. The skygrams are actually right. The CT has the right name on it. So after you have introduced yourself, like I'm Dr. Pal, the house officer today, are you Mr. Roy and are you aged 72 years? Or you can offer to say that, are you Mr. Roy? Can you give me your date of birth, please? So it depends on how you wish to proceed. I usually do not ask the date of birth because if the patient fumbles, I again lose 10 seconds. So I would just verify the age of the patient from my side if it is there on the summary. If it is not there on the summary, unfortunately, I have to ask the patient. Then also, it's a better idea to ask about the age flatly because he'll give you the date of birth. And first of all, he'll probably have a problem matching the date of birth with the appearance of the patient, and thereafter you'll have to calculate the age of the patient from the date of birth at the back of your mind. That again takes away some of your time. And next, you have to take the consent that I would wish to examine your abdominal system. Like I'll have to look at you, look at your tummy, look at you as a whole, and then I might have a closer look. Then I would touch and feel your tummy, press on it, and I might tap on it and listen to the tummy with my stethoscope. I might also listen to your chest. I might also press upon your feet. So, is that okay? Guys, is
Yes, sir.
this
Yes,
okay?
sir. Yes, sir.
That's not okay because I have spent 45 seconds on this elaborate dialogue. I would only say, I wish to examine your abdominal system. I wish to examine your tummy, look, feel, tap, and also listen with your stethoscope if that is fine with you. That is absolutely what you do. You finish it off in 10-15 seconds flat. Do not say more than what is required because the examiner just wants you to hit the bullets. He just wants you to tap the buzzer so that he knows you are enough professional to do your job. And thereafter, you can position the patient. In most of the cases, the patient would be positioned on a couch. If the patient is lying flat and you wish to uh, start your examination in a uh, semi-incumbent position, you have to help the patient. Or if the patient is lying on a couch and you want the patient flat on the bed, you have to help it while doing so. You have to expose the patient properly, and before that, you certainly have to wash your hands. In each step, you'd have to ask the patient for permission. And before you start the examination, one more very important question you should ask. And what is that?
About pain,
Any
if the
pain
patient
or
has any
tenderness is
pain.
there.
Yes. Are you in pain? Simple. Do you have any pain? Do you have any pain anywhere? And I'll try to be gentle, but let me know if you have any discomfort. So you ask the patient not to wait till there's a pain that you have inflicted. You simply stop wherever he or she is uncomfortable. If it is a lady patient, you would be provided with a chaperone. If the chaperone is not there, make it a point that you ask for a chaperone. You'd certainly have a chaperone, or you have one of the lady examiners would act as a chaperone and ask you to continue with the examination in her presence. Next slide. So you start with a general inspection. And when I say general, remember the patient doesn't end with the tummy. You have to stand and observe the patient from the end of the bed. And you say like, I'll take a look at you from the end of the bed. I'll take a look at you from your foot end. And you look for scars, distension, masses, stoma, hernias, discoloration, indwelling catheters, and many more things. Not for any movements, including gastric peristalsis or pulsations, but do not spend a lot of time on that. If there's a visible pulsation, if there's a visible peristalsis, it is going to be obvious. If there's a normal peristalsis going on in a very thin person, the examiner doesn't want you to spend 2 minutes to appreciate it. And you have to, when you describe the abdominal contour, you can call it is either flat or scaphoid, which means basically sunken, or protuberant. Do not say things like the abdomen is scarred or the abdomen is mildly distended, because just by inspection you cannot really comment upon distension. I hope you understand what I mean. Next slide, please. So these are just things to make you understand what all you need to remember to see, or what all things you might encounter while doing your inspection. As you can see a mass on the anterior abdominal wall. You can see a stoma with a bag. You can see various type of scars, and if there's a very visible scar, you can rest assured that that will give you a lot of information about patient himself or herself. You have deep icterus, and next slide. Look for the parotid enlargement. Look for xanthelasma. That is why we call it a general inspection. Telltale signs of abdominal disease, which is obviously present in front of your eyes, and you can already be overjoyed to find something positive to the present to the examiner. Next. So you can have cervical lymphadenopathy, the so infamous Virchow's nodes. You can have gynecomastia. You can have loss of hair, and it's always good to also look at the axilla to find out if the loss of hair continues still there, because body hairs are not very persistent in each and every patient. It might be scars, it might be more. In case of a very hairy person, you might not notice enough loss of hair unless you review with the axillary folds. Next. Next, you should examine the hands. You should look for clubbing. You know the abdominal conditions that can lead to clubbing, and you should keep all those in mind. You should now you can look at clubbing through various ways. You can ask the patient to oppose the nail enamels to find out what you call the rhomboid shaped chink of space, whether that is there or obliterated. Or you can also ask them to spread their hands and look from the side, and also look at the angle, the periangular folds. That will give you a clear idea about what all is going on. Look at the nails for leukonychia. You can find them in cirrhosis, hypoalbuminemia. You can have koilonychia. You should look for actually palmar erythema. But remember, in a creased and pigmented skin, or a skin that is altered due to occupational reasons, you might not be able to appreciate palmar erythema in proper sense. You have to feel for Dupuytren's contracture. Only seeing and diagnosing Dupuytren's contracture is not acceptable. And finally, check for the flapping tremor. When you check for the flapping tremor, it's absolutely fantastic to hold the back pressure with the wrist in the flexed position for a while, say 5 6 seconds before you release the pressure. There's no need to release it abruptly because if the patient flaps, he might simply flap from relaxing the uh, dorsiflexed wrist joint. Next, so these are a few examples like what you might get. Next, so in the face and the body, uh, you look at the eyes for signs of jaundice and anemia. At our point of time, we used to press down upon the skin, pull the skin to find out jaundice and anemia. These days, we ask the patient to look up and pull their skin to see the palpebral conjunctiva. But remember, for icterus, it's better to see it on the bulbar conjunctiva, right? And for that, it's better to pull the upper lid with your thumb and ask the patient to look downwards because that is not very well done by a patient himself or herself. Looking around the lips, you might find brown freckles, but I'm telling you, Puig syndrome and brown freckles are both extremely rare in our region of practice. But if you're going to traveling to a UK or Dublin, if you're giving your examination at Glasgow, you might be fortunate enough to find patients with brown freckles and PJ syndrome. You should inspect the mouth for central cyanosis, macro or microglossia. You know the reasons. You should ascertain the state of hydration by looking at the tongue, ulcers, breath, as well as signs of severe inflammation in the form of glossitis. You should inspect the trunk for camel de Morgan spots, striae, and signs of chronic liver disease, spironevi, gynecomastia, capitulitici, Cullen's and Grace Turner sign. The next slide will give you a quick idea about uh, very classical findings like these in your tummy patient. Next slide. So you can see aphthous, you can see venous prominence, varicosity, severe glossitis. You can see the freckles. You can see the McCullen sign, Gray Turner, as well as gynecomastia. Next. Abdomen can be divided in 4 quadrants. Patient should be lying on supine position. Remember that by kneeling down beside the patient, or semi squatting by the side of the patient, or taking a stool or a chair, you need to fix yourself in parallel with the tummy at least during palpation and close observation. Next. So you would quickly inspect again and confirm your earlier findings, ascertain the shape, the movement, scars, distension, prominent veins, striae, bruises, pigmentations, and visible peristalsis. If you're not certain about the finding in inspection, do not tell about it. And remember that do not say anything that you are not confident about to have seen, or you really do not know how you would relate such a finding to the case given to you. Next. So you have already sanitized your hands, and by this time, your hands might fall a bit cold. You should ensure that your hands are warm. You stand on the right side of the patient. Help to position the patient. Ask whether the patient feels any pain before you start. Begin with superficial examination and move in a systematic manner through all the abdominal quadrants and repeat palpation deeply before you do so. You always say that I'm going to lightly feel your abdomen or tummy. I'm going to press hard upon your tummy now. And in each stage, you'd say that, let me know if you are okay. Let me know if you are comfortable. Next, it's not imperative that you have to do your deep palpation using both your dominant and non-dominant hand, but it's a signposting to make the examiner understand that you are doing a deep palpation following a superficial palpation. Remember the organs, remember the quadrants, and proceed methodically but swiftly. Next, now continuing with palpation, you ask the patient if there's any pain spot in the tummy, and then perform light palpation starting away from the site of pain, looking at the patient's face. Feel for the tenderness, rebound tenderness, gouging, or rigidity. But remember, if you invoke a lot of pain unknowingly, or if the patient catches a breath due to sharp pain, then all your hard work goes down immediately. So be very cautious, be very particular, see for whatever you can find, but without distressing the patient. Perform a deep palpation while feeling for masses, and if you feel one, you should describe the mass later on in terms of size, shape, age, consistency, the percussion notes, vowel sounds, thrill, and or deep tenderness. In case of, say, a herniation that is there in the inguinal region, you might also have to tell the examiners whether it's a direct or an indirect inguinal hernia. Abdominal distension is caused by 8 F's, and while you deal with abdominal distension, uh, you should remember most of these causes in mind. If you keep these causes in mind, it's going to help you in the interview, in the interaction, and at the same time save you a lot of precious moments. Next, next part. So these are a few very useful signs, but remember, a Murphy sign is there in acute cholecystitis. Sometimes gallbladder related pancreatitis also might be a position, also might be a situation where Murphy sign is positive. So most probably you're not going to get it. And you should be at home with terms what actually we mean by tenderness, its discomfort and resistance to palpation. Involuntary girding is reflex contraction of the abdominal muscles, which is quite common in young ladies, in patients with a certain amount of sensitivity of the skin. Look for rebound tenderness where patient feels pain when the hand, the pressing hand, the palpating hand is relieved. So, release of compression actually brings about this tenderness, and hence it is called rebound tenderness. Tenderness coupled with rigidity is often present in case of perforated viscous, and there might be palpable muscles in various other places like enlarged organs. You can find a splenomegaly, a hepatomegaly, a tumor, or even impacted stool. You can find pulsation within the abdomen, and they are primarily, if not proved otherwise, they are due to an enlarged aorta. Next, so for palpation of the liver, remember that the patient needs to take deep breaths in and out slowly. You should start palpating far off, preferably in the right iliac fossa. Move hand progressively further up the abdomen. I appreciate a lot if your index border of your hand is moving parallelly or placed parallelly uh, with the thoracic contour of the thoracic cage. You should try to feel the liver edge check for the liver span by percussing from the top. As you can see on the right hand side of your screens, there's a percussion to find out the dullness and ascertain the liver span. Next. So here is how you do a palpation of the spleen. You start from the right iliac fossa, palpate with right hand while using left hand to press forward on the patient's lower ribs from behind. This is often asked as, certainly not in MRCP. Always remember it's a two-hand business. So if you are trying to palpate spleen with your right hand, what is your other lazy hand doing? As I said, you should feel along the costal margin. Next, bimanual palpation is not very easy, and if you can't elicit a positive finding at the end of bimanual palpation, nobody's going to give you even a semi-failed type of a grading. So to palpate the kidney, you should elevate the left flank with the left hand, palpate deeply with the right hand, and that is difficult to feel. And remember that once you're doing this, you are basically endangering yourself to come out with the comments. Just doing a bimanual palpation wouldn't help. You should be very confident about what you have just seen. Next, the fluid thrill is to be seen where you suspect an unusual amount of fluid in the tummy. You should place the palm of your left hand against the left side of the abdomen, flick a finger against the right side of the abdomen. Ask the patient to put the edge of the hand on the midline of the abdomen. If a ripple is felt upon flicking, we call it a fluid thrill, and that is confirmatory of ascites. In my long, long years of practice, there has been only one case where I have felt a very good fluid thrill in case of ascites within the tummy, but in most cases, it has been a clinical diagnosis or a diagnosis in terms of something called, what is the other sign you do? What is the other test you do for abdominal fluid?
Shifting
Shifting
dullness.
dullness.
Excellent. So next slide will show you. So this is something you already know. You have to tap upon the tummy, because straight away going and doing the shifting dullness wouldn't fetch you marks. So dull sounds are for solid or fluid filled structures. Resonant sounds are structures containing air or gas. And then you look for shifting dullness. You see, giving yourself a lot of pain while hitting your phalangeal bone to have a percussion note is not wise. You should practice, practice, and practice so that you might be able to do percussion, fruitful percussion, appreciable percussion note is even produced in a very, very obese person too. For liver, you percuss the upper and lower liver borders. Spleen percussion needs to be done from right iliac fossa. Spleen will always be dull on percussion. You have to check for ascites, assess for shifting dullness, percuss from umbilicus away from you towards the flank, noting the point of shifting dullness. You have to then roll patient towards you and leave your finger in the same position, wait for 30 seconds, and then process again. Uh, you do not have to wait for 30 seconds if you are quite confident about a good amount of fluid that has changed position and the dullness has shifted, because you can jolly well see that there's nothing on that side on the top of the swelling any longer. So you can breach this 30-second barrier if you are very confident. To assess for fluid fill, ask the patient to leave it. We have done that, and you have to percuss the suprapubic area for dullness suggestive of bladder distension. Next. So this is what we were talking. The maneuver is performed with the patient supine. You should percuss across the abdomen as per flank dullness with a point of transition from a tympanic note to a dull note. The patient is rolled on to his or her side away from the examiner, and the percussion from umbilicus to flank area is repeated. So, after you have basically cracked paces, you can do it in many other ways. For MRCP paces, please remember this technique by heart. And finally, when ascites is present, the area of dullness will shift to the dependent side, and area on top of the swelling will basically be completely different, because the area of tympani will be shifted toward the top. Once the patient is back, as you can see in the diagram, the dullness has shifted and the tympanic region has crunched on top of this accumulation of fluid, the pooch accumulation of fluid. Next. Finally, you have arrived at auscultation. Place the diaphragm of the stethoscope to the right of the umbilicus. Bowel sounds, borborhymi, uh, caused by peristaltic movements, occur every 5 to 10 seconds. Absence of bowel sounds might be due to a lot of ominous reasons, and also some other reasons where the conditions are not that malignant. Bruise over aorta, adrenal artery could be a sign of aneurysm and stenosis. Now, listening for 15 to 60 seconds is not a luxury here. Bowel sounds cannot be said to be absent unless they are not heard after listening for 3 to 5 minutes. And three things about bowel sound: are bowel sounds present? If present, are they frequent or sparse? And what is the nature of, or what is the quality of such sound? Now, you've done almost everything. Before closing your examination, your examiner might ask you, "That's it. Are you done?" So, before you say yes, before you proceed towards the grilling chamber where you would be grilled, do not forget mentioning about hernial examination, examination of the hernial orifices. And secondly, tell them that I would wish to do a rectal examination on this patient to gather more information. Now, before you finish, do also remember to tell them, the examiner might ask you that, "Are you done?" Then tell them that, "Sir, I would review the charts, and if possible, I would wish to do a rectal examination and also do a urine dipstick." Because as you remember the long list of cases that are possibly coming up in your paces, you might have a number of situations where this is very, very important. This also gives you a scope to invite questions like, what in this case might be the cause for blood in urine? And you have hit the jackpot, and you have actually driven the examiner in your own court, in your own terms. So, as my presentation ends here, and before I recollect if I have dropped anything in the way, I'll be happy if you have a few simple questions for me, because PACES is simple, and we would all love to keep it very simple. Can we go to the last slide, please? Where do you look for edema in a patient?
So in general or abdominal examination only?
Yes, in abdominal examination, what would you like to look for edema in a patient?
So on dependent area like sacral region of the patient.
Yes, and how do you look at the edema? If you see that the ankles are already edematous, you can straight away proceed to the ankle to find out, because that is also a dependent position till the patient was sitting.
Okay, sir.
If you wish to find out the sacral edema, do you want the patient to sit up, or you'd look for it by turning the patient to one side?
Sir, it will be more comfortable by turning the patient to the other side.
Yes, but the better idea is to help the patient sit up, because the next thing you're going to do is you have to cover the patient and thank him or her before turning to your examiner. You can always, what you can ask the patient is, say you have got a patient where the patient was already lying down on the couch and you have not at all seen the back of the patient, which is certainly an important part of the general survey. So this is an opportunity. You can ask the patient to sit up, look for the edema, tell that I am going to press upon your back, let me know if you have pain, and then cover the patient and ask him, would you like to lie down or should I raise the couch for you? Got it?
Yes, sir.
Okay. So questions you might have?
Sir, actually, I need to ask you a question.
Sure.
Sir, what if the patient has no complaints of any pain or tenderness, but at time of examination the patient feels the pain, like while doing Murphy sign in the patient. So, is that okay with that?
See, it is unlikely that the patient is having a pain and the patient is hiding it from you, because patients are real time patients and they are never trained to trick the examinee, the candidate. So, what you can do is, if the patient says ouch, or if the patient says ki lege geche, lagche, you only immediately apologize that I'm so sorry that I inflicted some pain. I'm so sorry that I made you uncomfortable. Do you wish me to discontinue examining you? The patient certainly will say that no, please continue. Or you might say that I'm so sorry I have hurt you. I'm not going to touch upon that place. I would request you to think and tell me again if you have pain anywhere else. Because if you say that, do you want me to discontinue? If he says yes, it's an impasse. It's a status quo, and the examiner will be happy to see you confused. So tell him or tell her that I'm so sorry. I gave you some pain. I'm not going to go back to the same area again. Could you please let me know if uh, every other area or you have any other pain point on your tummy or anywhere else on the body for that matter? So that's one good way to do it.
Okay, okay, sir.
Well, if there's nothing serious, good luck to all of you, and sincerely hope to see all of you in the MRCP PACES mocks that are coming up in February this year. Right?
Yes, sir. Thank you, sir. Thank you for your valuable time. And all the aspirants, if you have any question, please do ask.
And if they remember a question even after the end of the session, you can forward it, the same question to your FAST coordinator. She'll be in touch with me, and I can answer the question back to you.
Surely, sir. So, sir, shall we end the session now?
Yes, that's okay from my end.
Okay, sir. So, thank you. And all the aspirants, the next session of MRCP PACES will be probably on 18th January. The station will be respiratory. Thank you all.